Hi everyone, and in this video I'll be discussing something called antiplatelet drugs. Now whenever we think of antiplatelet drugs, we need to understand that these antiplatelet drugs will prevent a clot formation. Particularly, they will prevent a clot formation in an artery. My question to you all, will these antiplatelet drugs cut a clot? No, they will only prevent a clot. So the major use of these drugs is for prophylaxis. So let us discuss first and foremost antiplatelet drugs. We will understand some basics and then we go to the drugs. So let us begin. The antiplatelet drugs. So to understand this basic, let me tell you, usually there are two types of clot we come across. The clot which is present in the artery and the clot which is present in the vein. So this is a clot in the artery, and remember the arterial clot is mainly made up of platelets and some fibrin in between. But a venous clot is mainly made up of more of fibrin and entramped RBCs and WBCs. So that forms a clot, and this is the arterial clot. Let me write their name. This is the arterial clot, mainly made up of platelets, and this is a venous clot, mainly made up of the fibrin, and in that there is entrapment of WBC and RBCs. Now what is the problem if there is a clot in the artery? An arterial clot will lead to, in the CVS, it will cause what? In the CVS, it will cause the angina, and it can lead to myocardial infarction. So if there is a clot in the coronary artery, it can lead to angina as well as myocardial infarction. And in CNS, if there is a clot for the main artery supplying the CNS, the patient will have transient ischemic attacks. TIA stands for transient ischemic attacks, and patient may also have stroke. And the stroke, what we call it as, is ischemic stroke. Then in the periphery, if there is a clot in the peripheral blood vessels, that is artery, it will lead to peripheral vascular disease, so PVD. So for all this angina, MI, transient ischemic attack and stroke, peripheral vascular disease, what we use is antiplatelet drugs. So what we use is antiplatelet drugs. Yes. So for arterial clot, usually what we use is antiplatelet drugs. So they prevent the platelet aggregation. Remember, they will prevent the clot. To prevent clot, please understand, they don't break a clot. Okay. So these are antiplatelet drugs. What happens if there is a clot in the vein? The venous clot will lead to something called venous thromboembolism. So the venous clot will lead to venous thromboembolism. In that we have two important ones. One is called the pulmonary. One is called the pulmonary embolism. And one more is the deep vein thrombosis. So DVT stands for deep vein thrombosis. So for a venous clot, preferably what we use is, they are called as anticoagulants. So these are called as anticoagulants. Anticoagulants are also called by one more name, that is, they are also called as antithrombotics. So the question again here is, will these anticoagulants, or what you call as antithrombotics, will they cut a clot already formed? No. They are also used to prevent clot formation. That means they are mainly for prophylaxis. So we have two important ones, the antiplatelet drugs, the anticoagulants, and please tell me, what is the drug which cuts the clot? The clots are cut by a group of drugs, and they are called thrombolytics. So thrombolytics are the one which cut the clot. They can cut both arterial clot as well as venous clot. Is there any other name for thrombolytics? Yes, thrombolytics are also called as fibrinolytics. Another name for thrombolytics is fibrolytics. So we have three important things to understand. Number one, the antiplatelet drugs. Number two, the anticoagulants. And number three, the thrombolytics, which actually cut a clot. Now, when you consider all these three are preventing a clot formation, or they are cutting the clot, that is, the clot is cut by thrombolytics. What is the problem of all the three? The adverse effect of all the three is going to be bleeding. There is a major risk what the patient has to bear when the patient is taking these drugs. So I hope you got the concept now. What is antiplatelet, what is anticoagulant, and what is thrombolytic. So in this video, I'll be discussing the antiplatelet drugs. Clear? So let me take one more slide and explain to you. To understand antiplatelet drugs, you should understand how a clot forms in the artery. Now let me write an artery. This is an artery. And in the artery, we have the endothelium. So endothelium has a smooth lining. So, but whenever there is endothelial damage, the collagen is exposed. Whenever there is a damage to the endothelium, the collagen is exposed. Whenever the collagen is exposed, there is secretion of a factor called von Willebrand factor. And that will lead to platelet coming into the action. So platelet will come and stick to that place. So that is called platelet adhesion. So platelet will come and adhere, and once the platelet adhere, they will release certain substances. So they are called thromboxane A2. They will release ADP. Along with that, the tissues will release something called thrombin, and that will also help in recruiting more and more platelets to the site of damage. So when the platelet adhesion starts, then the platelets get activated. More and more platelet come to the site of action. So platelet activation occurs, and more platelets are recruited to the site of damage so that they can plug so they can stop the bleeding. They can plug that area. So when more and more platelets come and they get recruited, what happens? The platelets start aggregating. So there will be platelet aggregation. Platelet aggregation. So this is what happens in the normal physiology. So what happens here is, when there are platelets coming into the action, this one platelet, this one more platelet, they have to bind. So they will bind with the help of a protein called GP41, and they both are bound by something called the fibrin. So the connecting of this is through fibrin. Like this, more and more platelet come, and you will see an arterial clot. So this is the basics. Now our role is to stop the platelet attaching to each other so that a clot will not get formed. So let us see what happens when two platelets meet. So let us see, jab them met, what happens. Let me tell you, take a slide and tell you this. Let me write one platelet here. This is one platelet, and let me draw one more platelet here. So this is one more platelet. Now when two platelets come together, there is a binding site for that. So this is called the glycoprotein 2B3A. So this part, what I am marking now, that is called the glycoprotein 2B3A. So that will allow the attachment of fibrin. So fibrin gets attached here. Yes. Now who will activate the platelets apart from this? I told you there are certain substances released. So the ADP, which is released, will activate the receptor called P2Y12, and that will also help in more and more platelet aggregation. Another important is thrombin. Thrombin will activate a receptor called PAR. So this PAR receptor is also going to help in platelet aggregation. One more important aspect is the thromboxane A2. So it will also come to the picture and it will also activate the platelet aggregation. So everybody are pushing towards the aggregation. Is there any opposition for this? Yes. Now the opposition is from something called prostaglandin I2. So prostaglandin I2, it acts by increasing cyclic AMP. This cyclic AMP is the only one which inhibits the platelet aggregation. But we know that cyclic AMP is broken down into 5-AMP with the help of phosphodiesterase. So with the help of phosphodiesterase, it is broken down. Now, you pause the video and try to analyze. Now, you pause the video and try to analyze what are the targets where I can stop the platelet aggregation. Okay. So let me tell you that. Number one, I can block the GP2B3A. Suppose if I block this, the fibrin cannot bind. If the fibrin cannot bind, the platelet cannot get aggregated. Second, what if I block the receptor P2Y12? So that is the second important aspect. Third, what if I block the PAR? Fourth, what if I block the action of thromboxane A2? Fifth, should I have PGI2 agonist or antagonist? We can give agonist, but we don't have the drug. So what I can increase the activity of cyclic AMP. How do I do that? By inhibiting phosphodiesterase. So this is the fifth mechanism. So basically we have 5 different classes of antiplatelet drugs. The drug which blocks GP2B3A. GP stands for glycoprotein. The P2Y12 antagonist. The PAR antagonist. The drugs which act on thromboxane to decrease it. And the drugs which increase the activity of cyclic AMP, that is phosphodiesterase inhibitors. So we'll go one by one now. Okay, clear with that. So the first target what I am going to discuss with you all is, they are called as GP2B3A antagonist. So glycoprotein 2B3A antagonist. So what is the name of the drug? The name of the drug is called abiciximab. As the name ends with mab, obviously it's a monoclonal antibody. Now abiciximab has 2 important actions. It inhibits the glycoprotein 2B3A. Along with that, it inhibits one more protein called vitronectin. Now, one important pharmacokinetics of this drug is, this drug has a very short half-life. Half-life is very short. So if the half-life is very short, what we think is, we think that the drug is shorter acting, but actually this drug is long acting. Now, what is the reason why the drug is longer acting? Because it inhibits this with high affinity. So they inhibit this protein, and that is, the inhibition is with high affinity. They will bind, and they will bind it with high affinity. So they will not leave it easily. So that's why the drug will act longer. Now, please understand the drug is a mAb. So I cannot give it as oral drug. I should give it as injection. That is parenteral. So should the patient take it every day? So which prophylaxis should I use it? So it's used in the acute coronary syndrome, in myocardial infarction. It is also used during procedures, that is percutaneous coronary intervention. So whenever you are treating a patient with acute coronary syndrome, that is unstable angina and non-ST elevation MI, or ST elevation MI, or you are treating percutaneous coronary intervention, when you are putting a catheter inside the artery, there is a chance of clot formation. Because when you pass a catheter, the artery gets damaged, the endothelium gets damaged. So that is the use of this drug. Okay, patient will not take it every day because it's an injection. So in emergencies, it is a prophylactic drug. The adverse effect of the drug is mainly bleeding. I told you, all the antiplatelet drugs, the major adverse effect will be bleeding, and also they are shown to produce thrombocytopenia. So that is about abiciximab. But one more important pharmacokinetics I want to tell you, the drug is safe in renal failure. The drug is safe in renal failure. And should we reduce the dose in renal failure? No, no dose reduction required in renal failure. So very important point. So the first GP2B3 antagonist is called abiciximab. The other drugs which are the same mechanism are tirofiban and a drug called eptifibatide. Now remember, in pharmacology the drugs ending with tide, they are usually peptides. So eptifibatide is a peptide, and usually peptides are not given orally because they will be digested. So remember, these two drugs are injectables. So they are also used for percutaneous coronary intervention as well as in case of acute coronary syndrome. These are not oral drugs. So that is about GP2B3 antagonist. I'll repeat again: abciximab, tirofiban, and one more drug is eptifibatide. So the second target in antiplatelet therapy, what I told you, is P2Y12 antagonist. So these drugs are P2Y12 antagonist. Now in P2Y12 antagonist, we have two varieties of drug. The one which is irreversible antagonist, and one more drug are called reversible antagonist. So one is irreversible and reversible. So in irreversible, we have a drug called clopidogrel. So the drug name is clopidogrel. Now clopidogrel is a drug which is used for prophylaxis of both MI as well as stroke prophylaxis. The drug used is clopidogrel. Second drug is the name prasugrel. You read their name will have grel in their name, prasugrel, and you have clopidogrel. Now please understand, prasugrel is only used for MI prophylaxis. MI prophylaxis. Compared to clopidogrel, this drug has fast onset. What do you mean by fast onset? It can work faster compared to clopidogrel. And remember, both these drugs are prodrugs. And you know what do you mean by prodrug? Prodrugs are drugs which require activation. So even though prasugrel is prodrug, it will activate faster and it will work faster. Now, can we use it in stroke is a question. Can we use the drug prasugrel in stroke patient? No. In stroke patient, it is absolutely contraindicated because it has increased the risk of bleeding, that is hemorrhage, in stroke patients. So that is the reason prasugrel is, let me write, contraindicated in stroke prophylaxis. There was one older drug which was called as ticlopidin. So that is one more reversible drug, ticlopidin. So ticlopidin is irreversible drug. So it is clopidogrel, prasugrel, and we have a drug called ticlopidin. Ticlopidin mainly had two important adverse effects. One is called the diarrhea, and one more problem what we face with that is thrombocytopenia. So apart from bleeding risk, these are the other problems what we had to face with ticlopidin. So let me repeat again. P2Y12 antagonists, the irreversible blockers are clopidogrel, which can be used for both MI as well as stroke. Prasugrel, you can use it only for MI prophylaxis. Stroke, it is not used because the studies have shown increased risk of bleeding, that is hemorrhage in the brain. And both the grels are prodrugs. There was an older drug called ticlopidin. It is not used nowadays because of the risk of thrombocytopenia and diarrhea. Now, moving on to the reversible P2Y12 blockers. Reversible P2Y12 antagonist. So reversible P2Y12 antagonist, we have a drug by the name cangrelor. So that is grel. So you are adding R for this, grelor. This cangrelor is given intravenous. So if it is intravenous, obviously we use it in emergency like percutaneous coronary intervention as well as acute coronary syndrome. So it's an IV drug. One more drug is called ticagrelor. So ticagrelor is an oral drug. So this is used for MI prophylaxis, myocardial infarction prophylaxis. So this is about the P2Y12 antagonist. But in P2Y12 antagonist, there is one important aspect we need to understand, the story of clopidogrel. I explained this story with omeprazole also, but I will explain it again. This is a prodrug, we all know it. And it has to become active with the help of an enzyme called cytochrome 2C19. And that will make it active. Then only it will produce its anti-platelet activity, and then only it can prevent stroke and MI. Now certain people, they produce this enzyme very poorly. That means, what is cytochrome 2C19? They are microsomal enzymes. And what are enzymes? They are proteins. And proteins are derived from genes. So there are people called poor metabolizers. So these patients, if I use clopidogrel for prophylaxis, they cannot convert clopidogrel effectively to active one. And in them, clopidogrel will not be able to produce its maximum efficacy, or it will fail to work. So that is the pharmacogenetics you need to understand for this. So it's a pharmacogenetic issue. Now apart from that, you need to understand an interaction. Can we give clopidogrel with a drug called omeprazole? You all know omeprazole is a proton pump inhibitor, and omeprazole can inhibit the cytochrome 2C19. If it is inhibited, clopidogrel will not become active and the drug will not work. So this drug combination is contraindicated. What about other PPAs? You can give other PPAs but not omeprazole. So until now I have done with GP2B3 antagonist, then we are done with P2Y12 antagonist. The third target in antiplatelet drugs are, what is the third target? So PAR antagonist. So the PAR antagonist is called Orapaxar, and we have a drug called Atopaxar. So these are PAR antagonists, and you know that they block the action of thrombin, and these are also used for MI prophylaxis. So PAR antagonist. Then number 4, what about thromboxane A2? I have to decrease the activity of thromboxane A2. The name itself is telling you thromboxane A2 is responsible for platelet aggregation. So I can do it in two ways. Number 1, I can give a thromboxane A2 antagonist. So we have a thromboxane A2 and we call it as thromboxane A2 receptor antagonist. The name is called terutroban. You read the name. Tro means thromboxane, AN for antagonist. So terutroban, and it's still under trial. Okay, it's not approved till now. Second important aspect what we can do is we can decrease the thromboxane A2. Now what is the drug which decreases thromboxane A2? And that is called low dose aspirin. So low dose aspirin is the one which is known to decrease thromboxane A2. So what is the range for low dose? The range for low dose is between 40 to 325 milligram. So that is a low dose of aspirin. But do we use 40 milligram? That is a range. But whenever there is a MI and you want to use aspirin, the dosage should be between 160 to 325 milligram. That is the dosage what we use during an episode of MI. So why aspirin is the only drug we use it? Because when you use aspirin, it inhibits the enzyme COX-1 and 2 irreversible. So when you inhibit the enzyme COX-1 and 2 irreversible, and the platelets cannot synthesize thromboxane A2 because platelet lack nuclei. So when they lack nuclei, they cannot produce a new enzyme. So there is decrease in thromboxane A2. So like this, the low dose of aspirin works. Now moving on to the next important aspect, that is, I think we are done with the fourth one. The fifth one. The fifth one is by inhibiting phosphodiesterase, phosphodiesterase inhibitors. Now, when you inhibit phosphodiesterase, what happens? There is increase in cyclic AMP, and that will inhibit platelet aggregation. That will inhibit platelet aggregation. So, what are the drugs we have? One is called cilostazol. Cilostazol is a drug which is used to treat peripheral vascular disease. So, cilostazol is a drug which is used to treat peripheral vascular disease. And we have a drug called dipyridamole. So, dipyridamole is also phosphodiesterase inhibitor. So, remember, it is a phosphodiesterase inhibitor. And also, it increases adenosine activity. It decreases adenosine uptake. So, it's a drug which increases the activity of adenosine. So, where do I use it? Where do I use dipyridamole? Dipyridamole is used mainly for stroke prophylaxis. It is used for stroke prophylaxis. You may ask a question, why are we not using it in coronary steal phenomenon? No. It itself causes coronary steal phenomenon. We are not using it in MI prophylaxis. So, let me write the drug dipyridamole for you. Dipyridamole, one of the problem is it can cause coronary steal phenomenon. So, why it will cause coronary steal phenomenon? Because it will dilate the non-ischemic zone. So, in MI or in angina, the ischemic zone require more blood. But what happens here is when we give dipyridamole, it will dilate the non-ischemic zone where the blood is not required, and the ischemic zone suffers. So, that is called coronary steal phenomenon. So, that's why it is not used in MI prophylaxis, not used in angina or MI. Now, the drug is also used for one more thing, that is cardiac stress testing. So, the drug is used for cardiac stress testing. The name is dipyridamole. So, these are the antiplatelet drugs what I had to discuss with you. Now, if you see that most of the drugs are used mainly for the MI prophylaxis. So, let me give an idea for you where to use antiplatelet drugs in general. Antiplatelet drugs uses, so I can classify like this. You can use them in CVS, this is angina, and MI prophylaxis. Remember prophylaxis. And also they are used in emergencies like acute coronary syndrome, when you are doing a procedure called percutaneous coronary intervention. In CNS, they are used for transient ischemic attack, as well as they are used for stroke. Which stroke? Ischemic stroke. In periphery, they are used for peripheral vascular disease. All the antiplatelet drugs, one of the common problem is bleeding, because you are interfering with the platelet function. So, this is the use in CVS, CNS, and periphery. Now, what are the drugs which are approved for stroke prophylaxis? Majority of the drug I have told you where they are used, but stroke prophylaxis, which drugs are used? Not all drugs are approved for stroke prophylaxis. Remember the A, C, and D. Aspirin, clopidogrel, and D for dipyridamole. These are the only 3 drugs approved for stroke prophylaxis. And all other drugs, you can use it in serious conditions like angina and MI. But what is the reason why only 3 drugs are approved? The reason is other drugs have shown to increase the risk of hemorrhage in stroke. But these drugs have lesser risk. They also have, but lesser risk. That's why these are approved for stroke prophylaxis. You may ask a question, can we use aspirin in MI? Yes, obviously. Clopidogrel in MI? Yes. Can we use dipyridamole in MI? No. because it causes coronary steel phenomenon. So with that, I have discussed in this video the antiplatelet drugs. I told you the pathophysiology. I told you what are the targets. GP2B3 antagonist. They are all injectables. P2Y12 antagonist, clopidogrel, prasugrel mainly. Then cangrelor, ticagrelor. Then the PR antagonist, they end with Parksers. Then we have the drugs to decrease thromboxygenator, that is low dose aspirin. Then we have phosphodiesterase inhibitor, that is silastazole and diprodamol. So that is about antiplatelet drugs. Thank you all.